Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Welcome to the Deep Dive. Today, we're diving into, well, a really fascinating area where pharmacology, immunology, and biotech all meet. We're talking about therapeutic biologics and this big challenge that comes with them, immunogenicity.
Absolutely. These drugs, things like monoclonal antibodies, they've been, well, game changers for treating chronic conditions, rheumatoid arthritis, IBD, even cancer. But they're not simple pills, right? They're large, complex proteins from living systems.
And being proteins, these big molecules that aren't naturally ours, they carry this inherent risk. That's immunogenicity, basically, the drug triggering an immune response against itself.
And we have to be really clear. This is unwanted immunogenicity. We're not talking about vaccines here where you want that immune response. In this case, the body's getting confused, thinking the medicine is, an invader.
Right. And the stakes are all clinical. So when the body starts making these anti-drug antibodies or ADAs, what's the most immediate hit?
The impact is, well, pretty direct and measurable. It messes with the drug's pharmacokinetics, the PK. Basically, the drug gets cleared out of the system way too fast.
Way faster than intended.
Exactly. So you get less drug exposure for the patient, and ultimately, the drug just stops working. That's what we call a secondary loss of efficacy in the clinic.
Okay, so our mission today, for you listening, is to go beyond just defining it.
Yeah.
We want to give you a really solid framework. We'll look at how the body fights back, the different kinds of risks, product, patient, treatment strategy.
Walk through the testing protocols regulators demand, and then get into the data-driven ways we actually manage this to keep these therapies working long-term.
Okay, let's unpack this, starting at the molecular level. When a patient loses response because of immunity, what's the body actually making? These ADAs, anti-drug antibodies, and you're saying there are two main types, affecting quantity versus quality.
That's the key distinction, yeah. It really depends on where they bind. So first, you've got non-neutralizing ADAs. Sometimes people just call them binding ADAs. They attach to parts of the drug that aren't directly involved in making it work, like maybe the Fc region of an antibody, the sort of stem part.
So if they're not blocking the business end, how do they actually cause trouble? Is it just about how long the drug hangs around?
Pretty much. The damage is all pharmacokinetic. When these ADAs bind, they create these larger clumps, immune complexes. And the body's cleanup system, the reticuloendothelial system, thinks spleen and liver mostly.
The body's recycling system basically sees these clumps.
That's a great way to put it. It sees them tagged for disposal. So the spleen and liver pull these complexes out of circulation really quickly. They don't stop the individual drug molecule from working, but they drastically cut down the total drug quantity the patient has access to. Clearance goes up, trough levels drop.
Okay, so that's one way. Then there's the other group, the ones that cause actual functional failure, neutralizing antibodies, or NABs. Why are these the ones clinicians really worry about?
Well, because these directly hit the drug's functional quality. The immune system designs these NABs to bind right onto the drug's active site, the Fab region, the CDRs.
The part that actually does the work.
Exactly. By binding there, they physically block the drug. It can't connect with its target receptor or whatever it's supposed to bind to. The protein is basically turned off.
So that's a pharmacodynamic effect, a PD effect. It's not just about quantity, it's about whether it works at all.
Precisely. NABs tend to be more potent in causing failure, and finding them often correlates really strongly with a quick, complete, and usually irreversible loss of clinical benefit. So you've got these two main ways immunogenicity can undermine a therapy. Not enough drug around, the PK issue from binding ADAs, or the drug that is there doesn't work, the PD issue from NABs.
Or sometimes both at once, I imagine.
Oh, absolutely. You can definitely have both happening.
That distinction is critical. Okay, let's shift from the what's to the how. How does the body actually build such a strong, specific, and crucially lasting immune response?
Yeah.
You mentioned it's mostly T-cell dependent, TT. This is the real root cause.
Yes. This T pathway is fundamental, and it's worth walking through carefully. It's like a security checkpoint and authorization system. It starts when the biologic drug gets picked up and processed by what we call professional antigen-presenting cells, or APCs. Dendritic cells are a key example. Think of the APC as like a security guard analyzing a suspicious package.
Okay, so the guard finds this protein package. What's next?
It chops the protein up into smaller bits. These are the T-cell epitopes. Then these little fragments get loaded onto special display molecules on the APC surface, called MHC class II molecules. This loading onto MHC class II is vital because it determines who the APC can show these fragments to.
And the intended audience is the CD4 plus T helper cell. This is the authorization step, right?
This is the absolute crux. The APC presents this peptide fragment nestled in the MHC class II molecule to nearby T helper cells. If a T helper cell has the right receptor to recognize that specific complex, it gets activated. That T cell becomes the go signal.
Why is that T-cell go signal so vital for making it a lasting response?
Because without that T cell help, the B cells, the antibody factories can only manage a weak, sort of short-lived response. It's called T-independent. But when an activated T helper cell gives the right signals co-stimulation to a B cell that has also recognized the drug,
Okay.
that triggers the B cell to go full throttle. It starts making high-affinity antibodies, usually IgG class, and critically, it creates memory cells.
And the memory cells are why, if a patient develops a strong ADA response, you usually can't just stop the drug for a bit and then restart it, hoping it'll be fine.
Exactly. The immune system remembers. That response is baked in. So the really fundamental point here is that robust immunogenicity hinges on whether peptide fragments from the drug can bind effectively to the patient's specific set of MHC class II molecules. That's the bottleneck.
And that's what drug developers are trying to engineer out of new biologics, trying to remove those T-cell epitopes.
Precisely. That whole field of deimmunization is about predicting which peptides might bind MHC and designing the protein sequence to avoid them, so the APCs basically have nothing relevant to show the T cells.
That mechanism neatly leads us to part 2, thinking about risk. Immunogenicity isn't just one thing. It's driven by a bunch of factors coming together. We can group them maybe into 3 buckets: factors related to the drug itself, the product, factors about the patient, the host, and factors about how we give the treatment, the strategy. Let's start with the drug itself, product-related factors.
Yeah, and if you look at how monoclonal antibodies have evolved like over the last 30, 40 years, it's basically a story of trying to make them less foreign, more human, to reduce that intrinsic risk.
And you could almost see that story in the naming suffixes, right? The OMABs, ANXIMABs, ZUMABs, OMABs. That's like a timeline of decreasing mouseness.
Exactly. We started way back with the murine antibodies, the OMABs. Murimotab CD3 is a classic example. These were 100% mouse protein. The human immune system saw them as completely foreign.
High risk, big time.
Very high risk. You got strong human mouse antibody HMAb responses. That was kind of the baseline problem.
Then came the first step towards humanizing. The chimeric antibodies, the oximabs, like infliximab or rituximab, a hybrid approach.
Right. They took the mouse bits that actually bind the target the variable regions and fuse them onto a human constant region backbone. So maybe 65, 70% human. That helped a lot. But those mouse variable parts were still pretty obvious to the immune system, still immunogenic.
Next up, trying to get even closer, humanized antibodies, the ZUMABs, like trastuzumab. Here, they only kept the tiny mouse loops that do the actual binding, the CDRs, and put them onto a human framework. So now we're talking maybe 90, 95% human sequence.
Another big improvement, risk went down again. But the real twist, maybe, came with the latest generation, fully human antibodies, the UMABs. Think adalimumab, pembrolizumab. These are derived entirely from human gene sequences using things like phage display or transgenic mice. On paper, 100% human should be perfectly tolerated, right?
But they're still immunogenic. How? If the sequence is human, what's left to react to? Is it about the 3D shape being weird?
That's exactly it. It's a bit of a paradox. Even with a fully human sequence, the final structure, especially in those engineered binding regions, the CDRs, can fold up in ways that are completely novel. These unique shapes are called idiotopes.
Idiotopes, okay.
And because the body's immune system hasn't seen these specific shapes during its development of tolerance, it can still flag them as foreign, even though the building blocks are human. So this conformational foreignness means even fully human biologics carry an immunogenicity risk.
Wow. So it's not just the blueprint, it's also about how the final product is made and handled, the quality control aspect.
Oh, absolutely critical. Think about protein aggregation. If the protein molecules clump together, maybe because of bad storage, temperature changes, shaking,
Yeah.
these aggregates are like big red flags for the immune system. They're potent danger signals that can kick off strong immune responses, sometimes even bypassing the usual T-cell checks.
Which is why pharmacist counseling on proper storage and handling is so important, isn't it? It's not just about stability, it's about immunogenicity too.
Definitely. Then you have more subtle things from manufacturing, like post-translational modifications or PTMs. The cells used to make the protein might add sugar patterns, glycans that aren't quite human.
And non-human sugars.
Right. These create neoepitopes, new targets the immune system sees as foreign. And finally, you can't ignore impurities. Tiny amounts of leftover stuff from the production cells host cell proteins, DNA bits. They might not be immunogenic themselves, but they can act as adjuvants.
Like boosting the signal.
Exactly. They ramp up the overall immune response to the actual drug protein. So clean manufacturing is key.
Okay, that covers the product side. Let's pivot to the patient-specific determinants, the host response. This feels like where personalized medicine really comes in, starting with our genes.
Genetic predisposition is, well, probably the most fundamental layer. We talked about the T-cell response needing that MHC class II presentation. If a patient's particular MHC molecules just can't physically bind well to the drug's peptide fragments,
Then the T cells never get properly activated.
right, a strong response just doesn't get off the ground, so your specific HLA genotype acts like a gatekeeper.
And is there a specific gene variant and HLA type that we know is a big risk factor for common biologics, something clinically validated?
Yes, there's a very well-established one, the HLA-DQA105 allele. Having this allele significantly increases the risk of developing ADAs against anti-TNF drugs, especially infliximab and adalimumab, particularly in patients with IBD.
So for IBD patients getting anti-TNFs, knowing their HLA-DQA105 status could actually predict their risk? That's huge.
It's a strong predictor, yes. It doesn't guarantee ADAs will form, but the risk is much, much higher.
And thinking bigger picture, does this suggest a future where we might screen patients beforehand, like we already do for some drugs?
Exactly. The precedent is there. Think about the HIV drug abacavir. We have to screen patients for the HLA-B 57.01 allele before starting treatment.
Because of the hypersensitivity risk, right?
Precisely. HLA-G 57.01 strongly predicts a severe, potentially life-threatening abacavir hypersensitivity syndrome. It's mandatory screening. So the logic follows. If we have a strong predictor like HLA-DQA105 for anti-TNF immunogenicity,
Maybe we should be screening for it too.
it points towards a future where maybe patients with that allele are automatically started on combination therapy with an immunosuppressant, or maybe we choose a biologic from a different class altogether for them right from the start. Preemptive risk mitigation.
Beyond DNA, what about the patient's immune history, especially if they've already been on a biologic?
That's the idea of prior biologic exposure and setting up immunological memory. We see this concept of class-specific priming. If a patient develops high ADAs against, say, infliximab and anti-TNF,
Their immune system has basically learned how to target that type of molecule.
kind of, yeah. They've shown they can mount a T-cell dependent response against that anti-TNF structure. So if you then switch them to another anti-TNF, like adalimumab, which is structurally similar,
Are they guaranteed to react? Is it direct cross-reactivity?
it's usually described more as a strong predisposition or priming effect rather than strict cross-reactivity between the antibodies themselves. The immune system is already primed, so it's much more likely and often faster for them to develop ADAs against the second drug in the same class.
Which has big implications for treatment choices after failure.
Absolutely. If someone fails an anti-TNF due to high ADAs, that history strongly pushes you towards switching to a drug with a completely different mechanism outside the anti-TNF class to avoid that prime response.
Okay, that brings us to the third risk bucket, the treatment-related variables, how we actually use the drug. This feels like the area clinicians and pharmacists have the most direct influence on day to day.
Definitely. And let's start with something a bit counterintuitive. The relationship between dose and interval. For quite a few biologics, especially some anti-TNFs like infliximab, we actually see an inverse relationship. Higher doses are often linked to lower rates of ADA formation.
Wait, higher dose, less immunogenicity. That seems backwards. Wouldn't more drug mean more chance for the immune system to see it?
It does seem odd, doesn't it? One leading theory is about maintaining high dose tolerance. Keeping drug concentrations consistently high might saturate the system, the APCs, the B cells perhaps inducing a state of non-responsiveness called anergy, or even deleting the specific immune cells that would react. It prevents the T to VAT pathway from really kicking off.
So consistency is key, which implies that interrupting therapy would be bad.
Exactly. Intermittent therapy, big gaps between doses, or stopping treatment for a while, like a drug holiday before surgery, that's a major risk factor for breaking tolerance. When you re-expose the patient after a break, the immune system often sees it fresh, and the risk of ADAs goes way up.
This ties back to that idea of a tolerogenic window, doesn't it?
Perfectly. The goal isn't just a therapeutic drug level, it's maintaining a trough concentration that's also high enough to keep the immune system suppressed or tolerant towards the drug. It's that clinical Goldilocks zone, enough to work and enough to maintain tolerance.
And there's a very common strategy to help achieve this, especially with drugs known for immunogenicity: concomitant immunosuppression.
Yes, using drugs like methotrexate or azathioprine alongside the biologic, particularly when starting anti-TNFs like infliximab, has a huge amount of data showing it significantly reduces both how often ADAs form and how high the titers get. It's a really powerful tool, especially for higher risk situations.
Okay, one last treatment factor: route of administration. Subcutaneous, SC, versus intravenous. On paper, injecting under the skin sounds like asking for trouble immunologically.
Theoretically, yes. The subcutaneous tissue is packed with very potent APCs, similar to why we give vaccines into the skin or muscle. An SC injection creates this local depot, a sustained release.
Which sounds exactly like how you'd want to design something to stimulate immunity, like a vaccine.
It does have those pro-immunogenic characteristics, but the clinical reality, especially for the newer, highly humanized or fully human biologics, often doesn't quite match the theory.
So the real-world data doesn't always show higher ADA rates with SC compared to IV.
Surprisingly often, the rates end up being comparable. It suggests that for these modern biologics, the inherent humanness of the molecule and the patient's own genetics might be stronger drivers of immunogenicity than the route itself. The product design might be good enough to overcome the theoretical risk of SC injection.
Interesting. Okay, so once treatment starts, we need to watch for this. That leads us to clinical surveillance, testing, and TDM. Regulators have a pretty set way labs should approach testing, right? This 4-tiered approach.
Yes, and it's designed for rigor. You start wide, then narrow down. Tier 1 is the screening assay. The goal here is pure sensitivity. You want to catch every possible positive. So you set the bar low, meaning you'll tolerate some false positives, maybe around 5%, just to make absolutely sure you don't miss any true positives. Minimize false negatives. That's the aim.
Anything that flags positive there goes to Tier 2. The confirmatory assay. This is where you weed out the false alarms.
Exactly. You need to prove the signal is actually specific to the drug. The common way is using competition. You take the patient sample and flood it with the actual drug product. If the signal you saw in T1 was really due to ADAs binding the drug, adding loads more drug should block that binding, and the signal should significantly decrease or disappear. That confirms specificity.
Okay, confirmed positive. Then you want to know how much ADA is there. That's Tier 3, titration.
Right. Titration gives you a semi-quantitative measure of the response strength. You take the confirmed positive sample and dilute it, half it, quarter it, and so on until the test signal becomes negative. The last dilution that's still tested positive is reported as the titer, like 1.10 or 1.100.
Giving the clinician a sense of scale, is this a weak flicker or a major response?
Precisely. And finally, the most clinically relevant question. Are these ADAs actually stopping the drug from working? That's Tier 4. The neutralizing antibody NAB assay. This is often the crucial piece for deciding what to do next. Ideally, the FDA prefers cell-based assays for this. These try to mimic the drug's action in a lab setting. So if the drug is supposed to block cell growth, the assay tests if the patient's antibodies prevent the drug from doing that.
More functional.
Yeah, more functionally relevant. But sometimes labs use simpler competitive ligand-binding assays, which just check if the ADAs physically block the drug from binding to its molecular target in a test tube. Cell-based is generally seen as better if feasible.
Now, The technology used for these assays matters hugely too, doesn't it?
Yeah.
Especially this issue of ELISA versus the newer ECL platform.
Oh, massively. ELISA enzyme-linked immunosorbent assay is the older workhorse, but its big weakness here is drug interference. Think about testing a sample taken just before the next dose, a trough sample. Even at trough, there can still be quite a bit of the therapeutic drug floating around.
And that leftover drug in the sample can basically hide the ADAs from the test. It binds them up before the assay can see them.
That's exactly the problem. The drug in the sample essentially outcompetes the assay for binding to the ADAs. This can lead to a false negative result. The patient might be developing clinically significant ADAs, losing response, but the test comes back negative because the assay couldn't detect them through the drug interference. It's a major pitfall.
Which is where the newer tech comes in.
Right. ECL, electrophenoluminescence platforms like those from MSD, mesoscale discovery, are designed differently. They generally have much higher sensitivity, a wider dynamic range, and critically superior drug tolerance. They are much better at detecting ADAs, even when there's a fair amount of drug present in the sample.
So they can find the needle in the haystack, so to speak.
A much better chance, yes. Which means they're generally more reliable, especially for analyzing those critical trough samples.
This is so important for pharmacists and clinicians interpreting results. The ADA rate reported in a drugs package insert or a clinical study might be completely different from what your local lab finds just because they use different assays with different drug tolerances.
Absolutely. You cannot just compare ADA percentages across studies or labs without knowing the assay details, especially the drug tolerance level. A 10% rate found with a high tolerance ECL assay means something very different clinically than a 5% rate found with a low tolerance ELISA. Interpreting these results requires understanding the test's limitations.
And all this testing feeds into the broader strategy of therapeutic drug monitoring, TDM. Often we think of TDM reactively testing levels after a patient loses response, but you're advocating for a more proactive use.
Yes. A sudden drop in the trough drug level is often the very first sign that immunogenicity is becoming a problem, maybe even before clinical symptoms worsen. But beyond just detecting failure, proactive TDM can be used to prevent it. By routinely checking drug levels and adjusting the dose or interval to keep the patient consistently within that tolerogenic window we talked about earlier, high enough to work, high enough to maintain tolerance. It becomes a strategy to actively suppress ADA formation and keep the drug working longer. TDM as prevention, not just diagnosis.
Okay, let's put it all together. We have the risks, the testing, now the management and intervention strategies. This is where the TDM and ADA data really guide clinical decisions, right? There's almost an algorithm.
Exactly. Integrating the trough drug level with the ADA status takes away a lot of the guesswork when a patient starts losing response. It points towards the likely cause and the best next step. We can think about three main scenarios.
All right, scenario one, pharmacodynamic PD failure. What's the data signature and what's the move?
Okay, here the TDM shows an adequate or even high trough drug level. The drug is definitely present at therapeutic concentrations, but clinically the patient isn't responding anymore.
So the drug is there, but the disease pathway has changed or isn't sensitive to that mechanism anymore.
Precisely. It's a mechanism failure, not a drug exposure failure. So the action is clear. Switch to a biologic with a different mechanism of action. Trying to increase the dose of the current drug is pointless. More drug won't help if the target isn't responding.
Makes sense. Okay, scenario two, non-immunogenic PK failure.
Here, the patient has a low trough drug level, but crucially, ADA testing comes back negative or low non-neutralizing. So the drug is disappearing too quickly, but it's not because of an immune attack.
Why else might it clear fast?
Could be several things. Maybe the patient has very high disease activity that's just consuming the drug faster. Maybe they're just a fast metabolizer for that particular drug. Or maybe the dose was just too low to begin with.
So what's the action here?
Because the immune system isn't the problem and the drug's mechanism is still presumably fine, the move is to intensify the current therapy. Increase the dose, shorten the dosing interval, or maybe both. Try to boost that trough level back into the therapeutic and tolerogenic range.
You can salvage the therapy. All right, and the classic case, scenario three, immunogenicity-driven PK failure.
This is the textbook immunogenicity picture. You see a low or undetectable trough drug level, and testing reveals high levels of ADAs, often confirmed to be neutralizing antibodies, NABs.
The smoking gun. The immune system is clearing the drug and/or blocking it.
Exactly. The ADAs are clearly driving the treatment failure. The action here is usually definitive. Switch to a different biologic agent. And remembering that class-specific priming issue.
You probably want to switch to a drug from a different class if possible.
That's often the preferred strategy, yes. If they failed an anti-TNF due to ADAs, switching to, say, an anti-integrin or an IL-1223 inhibitor might offer the best chance of avoiding a repeat immunogenicity problem.
That algorithm really clarifies things, but immunogenicity isn't always about slow loss of efficacy. Sometimes it's sudden and severe hypersensitivity and infusion reactions.
Right. These can range from mild stuff like rashes, itching, flushing during or shortly after infusion, all the way up to severe anaphylaxis with breathing difficulty and blood pressure drops.
How are these managed? Pre-medication seems common.
The immediate management is stopping the infusion and providing supportive care. Antihistamines, steroids, epinephrine if needed. Prophylactic pre-medication with antihistamines and sometimes steroids is widely used. But interestingly, the hard evidence supporting routine pre-meds for all biologic infusions to prevent mild reactions is actually a bit inconsistent. For preventing severe anaphylaxis in known reactors, it's different.
But what if a patient has a confirmed severe allergy, like anaphylaxis, but that specific biologic is absolutely essential and there are no other options? Is there anything that can be done?
Yes, in those very specific high-stakes situations, there's a specialized procedure called rapid drug desensitization, or RDD.
Desensitization sounds complex. How does that work?
It's a fascinating application of immunology. The idea is to induce a temporary state of tolerance by giving the drug in incredibly tiny, gradually increasing amounts over several hours. You start with a minuscule fraction of the dose.
Why does that help?
It's thought to slowly engage the mast cells and basophils, the cells that release histamine, and cause allergic reactions without triggering them all to degranulate at once, which is what causes anaphylaxis. You sort of gently coax them into releasing their content slowly or becoming unresponsive, allowing the full therapeutic dose to eventually be given safely during that session.
And there's a standard protocol for this,
Yeah.
the 12-step 3-bag method.
That's the classic approach, yes. It's incredibly meticulous. The pharmacy prepares 3 IV bags with different concentrations of the drug, maybe 1.10, then 1.0, then the full concentration. The infusion starts with the most dilute bag at a very slow rate, and then typically the rate is doubled every 15 minutes or so, progressing through the bags according to a strict 12-step or similar protocol.
Takes a long time, I imagine.
Oh yeah, the whole process can take 6 hours or more, but it allows patients who are truly allergic to safely receive a drug they critically need.
And what's the catch? Is the tolerance permanent?
That's the crucial point. No, the tolerance induced by RDD is temporary. It generally only lasts for that dosing cycle. If the patient misses a dose or there's a significant gap in treatment,
The allergy comes right back.
very likely, yes. They would almost certainly need to repeat the entire lengthy desensitization protocol for their next dose. So adherence to the treatment schedule becomes absolutely paramount once someone is on an RDD protocol.
Okay, this has been incredibly thorough. A real deep dive. We've seen immunogenicity's complex product, patient, treatment, all play a role. And the main clinical hit is usually that PK shift causing drugs to fail.
And it really highlights the evolving role of the clinical pharmacist, doesn't it? Moving towards proactive risk management, counseling on storage, pushing for TDM, understanding the nuances between ELISA and ECL.
Right, interpreting those assay results critically, knowing that a negative might not be truly negative if the wrong test was used, and then applying that structured algorithm for treatment failure, guiding evidence-based switches.
Ultimately, the real excitement is in prevention. Combining what we know about genetic risk factors like HLA-DQA105 with proactive TDM to keep patients in that tolerogenic window, that feels like the clearest path forward.
Moving from just reacting when drugs fail to actively preventing immunogenicity from developing in the first place.
Exactly. That's how we maximize the benefit of these amazing therapies for more patients for longer.
So here's a final thought for you, our listener, to chew on. If we really committed to this personalized approach, maybe routinely screening high-risk patients for known genetic markers like HLA-DQA105 before starting therapy and using proactive TDM aggressively, could we significantly drive down immunogenicity rates? Could we reach a point where it becomes a much rarer reason for treatment failure, ensuring more patients get the full long-term benefit of the right drug? The tools and the knowledge seem to be aligning.
Something to consider. Thanks for joining us on the deep dive.
We'll see you next time.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.